And good morning again, everyone. Thank you very much for joining us on this bright, beautiful, sunshiny day. And again, welcome to our global viewers that are joining us. It's so nice to see people from around the world. And I was taking a look at our list here before we got started here. We've got several people joining us from the UK, as well as New Delhi, Toronto, Ottawa, Edmonton, Vancouver, and the United States, LA, South Carolina, North Carolina, Maryland, Florida, Brooklyn. So we're quite a global show today, in addition to all of our Calgary viewers. And thank you to those that have joined us again. And so look forward to our presentation today. I think we've got lots of great things to learn. And we thank you for joining us for this presentation, Women's Heart Health, which is part of the Kerby Center's ongoing series of health, wellness, financial management, information, and entertainment presentations. As we begin here, as we gather today, it's vital to also remember the peoples who have gathered here for millennia. This is the Treaty 7 land of the Indigenous peoples of Southern Alberta, the Blackfoot Nations of Siksika, Piikani, Kainai, and the Tsuut'ina First Nation, the Stoney Nakoda Nations of Chiniki, Bearspaw, and Wesley, and the historic home of the Northwest Métis and Métis Nation of Alberta Region 3. It is with the goal of reconciliation that we acknowledge the land on which we gather and thank the elders of these nations for their timeless contributions to this land. As you all know, this month has been a very busy month. February is Heart Month, as well as I hope everyone had an enjoyable Valentine's Day weekend and Family Day weekend. So it's been a rather eventful month. And I think that the fact that it is Heart Month, and we are all looking into our hearts, that it's a good time to be mindful of our heart health. And not only for our own, but for those that we love as well. As you'll hear today, for women, the signs of a heart attack may not be what you expect them to be. Would you know how to tell the signs if you were having a heart attack or if your heart was at risk? Today, we are pleased to welcome Dr. Karen Nerenberg. Dr. Nerenberg is an associate professor and clinical scientist at the University of Calgary, working in the area of general internal medicine and obstetric medicine. Dr. Nerenberg's clinical and research interests focus on the prevention of heart disease in young women after common pregnancy complications, including the high blood pressure disorders of pregnancy. Her research is supported by Heart and Stroke's CIHR's Women's Heart and Brain Health Mid-Career Research Chair. Dr. Nerenberg, thank you so much for joining us today. I know that you've had a very busy Valentine's weekend providing several presentations as part of the Wear Red Canada campaign and women's heart health awareness activities. Tell us why it's so important for all of us to be more conscious of preventing heart disease, and how can we better understand the signs of a heart attack in women?
Did you want me to leave that into the presentation, Colleen, or just?
Sure, absolutely. I turn it over to you.
Sounds good. I'll just share my screen there and hopefully, let's just see here. Colleen, are you seeing just the slides, or are you seeing presentation mode?
I'm seeing presentation mode, yes.
Like with my notes on the side and the slides at the
No, I'm sorry. I'm seeing full screen. Sorry.
Okay, thank you. So thank you very much for the introduction, and very kind of you to allow me to come speak today about women's heart health, and hopefully I'll answer some of the questions there. And really, when we speak of heart health, we really do include men in these conversations too, but we want to just talk about how women and men's hearts are a little bit different, and how knowing that information actually it can improve health outcomes for women and for men as well. So I don't have any disclosures today in terms of financial disclosures. All my research is funded through different government organizations and not from pharma companies. Um, I again would like to acknowledge the traditional territories that I'm a visitor on, and thank Colleen for already doing the that land acknowledgement. I'm hoping by the end of this talk that everyone who's on the call today will understand some of the challenges that are specific to women when it comes to heart disease. And we want to talk a bit about the differences between males and females in that regard. And that comes across with symptoms, different diseases that females experience and compared to men, the testing, how that might be different in a female, treatments, and how different biological points in a woman's reproductive life course from fertility to menopause might actually change her cardiovascular risk, and how the woman's social context actually comes into play too. What you're going to hear me talk a little bit about is I tend to use the word women, and maybe I shouldn't at times, but when we talk male and female, that really talks about the biological sex. And when we talk about men and women, that brings in some concepts of gender and social roles and identity and whatnot. And so if I am referring to women, I do, for the most part, mean that in a biological sense of the XX chromosome and whatnot. There's an important point too that I want to talk about is how can we improve women and men's heart health in general. There's a great video that I do like to acknowledge at the beginning of this talk, and it's called A Typical Heart. And it was a documentary actually made here in Alberta by two Alberta filmmakers, Laura and Chris Beauchamp from Grand Prairie. And it was led by a community paramedic in Toronto, Christina D'Alessandro. And it was her observation as a paramedic when she picked up women who had heart symptoms, that they had different symptoms. They also had different findings on their ECG, the heart monitor, and their blood tests weren't the same. And that led her to really wanting to do a deeper dive into what is different between women and men's heart health. And it led to this great documentary that you can find on YouTube if you're interested. And it really talks about the woman's story and how we really need to amplify the story of women. And my area of research in particular is how in pregnancy kind of identifies which women might be on the trajectory to heart disease, and how we can modify that. And you'll hear through their stories that half of these women had a pregnancy complication like high blood pressure disorders or preeclampsia, preterm birth, etc. But very powerful documentary, and also helps women advocate for what they need to do to take care of their own health. So big shout out to them for doing this documentary. Given that it is heart month in February, the Heart and Stroke does some amazing work in heart disease management and prevention. And many of you might be familiar with the report that they released a couple years ago called Misunderstood. And the theme of that report was really starting to open up researchers and patient and clinician eyes as to how heart disease in women is under-researched. About a third of research that's gone on in the past has actually included women. In the past, it was really only focused on men. And we now know that only looking at males in scientific research doesn't always apply to females. And so the real shift is to start include more women in clinical trials and research so that we can answer questions for everybody. We also know, though, that clinically, that 53% of signs of early signs of a heart attack tend to be missed in women. Women may not recognize the symptoms, and we'll get into that in a minute. And it's often not recognized by healthcare providers. And that word atypical, so a typical heart, comes from the fact that as doctors, we're actually taught that female specific symptoms are atypical. They're not quite the same as the classic male symptoms. And we'll get into that shortly as well. We do know that if a female presents to hospital, she's less likely to receive the same tests as a male might. So leading to this underdiagnosis that women are not getting the same tests. And this is where we need to push and use our voices to get those tests. We also know that the tests that are done are less accurate in women because, again, developed in men. The normal ranges were set based upon male biology, not female biology. And so there's a huge underdiagnosis there. We also know that it's undertreated, that women receive fewer standard therapies when we compare that to men. And that's even occurring here in Alberta, looking at our Alberta data. But generally, there's a huge under-awareness that heart disease is common in women. Women are 5 times more likely to die of heart attack than they are of breast cancer. And yet what we worry more about is breast cancer and these cancers. And so how do we change that messaging? In 2008, so over 10 years ago, about 40,000 women were dying of heart disease every year in Canada, and yet it was under-recognized by people and by researchers. Further, only 20% of physicians in general actually talk to women about their heart health. Their well-visit exams focus on, pap smears, breast exams, and we don't talk about all the heart-related conditions too. And I like to throw in an extra under that it's under-prevented. We have an opportunity throughout the whole life course of women to prevent heart disease from happening, and that's what my research really focuses on. One of the slides that really struck me as well was that it's under-survived, that if a woman has a heart attack, it's much more deadly and she's less likely to survive than if a male has a heart attack. Similarly, when we talk about stroke, same underlying biology of a clot in the blood vessel in the heart versus a clot in the blood vessel in the brain. 1/3 more women die of a stroke than men as well. And we need to start working on how we can improve these outcomes. And we often call this the gender gap between outcomes in heart and stroke for men and women. So I hope I've set the scene that, there is this under, but we can change this together as a community. So importantly, the symptoms. We want to talk a little bit about the symptoms. And so when we see it on TV or whatnot, men typically get like the crushing chest pain, may radiate up to the neck or down the arm as well, shortness of breath, sweatiness, and dizziness. And women can have the same symptoms. So the classic crushing chest pain or pressure or heaviness, like an elephant is sitting on the chest. But women actually experience some different range of symptoms. They may have more shortness of breath, more breathing difficulties. It's just hard to breathe. They may get more nausea and vomiting that goes with it. They may get more jaw pain. I see a lot of women that actually have had jaw pain for years and didn't realize that it was related to their heart and went to see dentists and whatnot. Excessive fatigue, something's changed. They just don't feel quite right and they can't describe it as well. So as doctors, we really need to be aware of this, but as the health, as the people out in the community, we also need you to be aware that these may be symptoms that something's not quite right with your heart and to get some investigations there. I just actually want to go back to this quote I have on the bottom by Carolyn Thomas, and she's actually a very strong advocate for women's heart health out in BC. She runs a blog called Heart Sisters, and she's often interviewed about her own experience and just how it was suboptimal and how we can do better for women. So if anyone's interested in following Carolyn Thomas, either on Twitter or on her blog, as well, really good research that she posts on there too. When we talk about the different types of heart disease, there's standard ones that occur in both males and females, and it involves the large arteries. So the blockages develop over time in the large arteries, and that's typically what we think about for the heart attacks, is that these arteries get clogged and leads to death of some of the heart tissue in that area. We also know that there's heart rhythm problems. So that's the arrhythmia where the heart may be going too fast, or a tachycardia. It may be going too slowly, or bradycardia, needing a pacemaker, or it may be jumping all over the place irregularly, like atrial fibrillation. We know a large percentage of men and women in Canada have problems with their heart valves, particularly over time. Some of the valves get tighter over time. The aortic valve gets tighter, and the mitral valve gets a little bit floppier or more regurgitant. And we also know that there's a higher increase in heart failure, and that's where the muscle or the pumping muscle of the heart is weaker and doesn't pump as effectively. And finally, there's a whole group of the congenital heart disease where people were born with a heart defect, and often that requires surgical correction at birth. And these are pretty similar in terms of the numbers of males and females with each of these conditions. And we do know that all these are increasing over time in Canada. So the Heart and Stroke a couple of years ago produced a report showing that about a 50% increase in structural heart disease, 25% increase in heart failure, and 20% increase in stroke over the years too. So we're starting to see higher increases in all these conditions in Canada. Now, when we talk about female specific heart problems, it goes beyond the large artery or the classic heart attack. And this is where the list gets really quite long. And I'll put them all up here for you. But we get troubles with SCAD, or where there's a tear in the heart vessel. And this is becoming more and more common, that commonly recognized that women are having these small tears called SCAD. We also know that women can get the small blood vessels. They're more likely to have the small blood vessels affected by hardening of the arteries or improper relaxation. And that's called microvascular disease. And it's a little bit harder to treat. We also know that women can have clean arteries when they do an angiogram or the dye test to go and look at the arteries. We know that women are also more prone to getting spasms of their heart vessels too, and that heart failure looks different in women who've had with heart failure. When we do an echo, or the cardiologists do an echo of the heart function, that's again how hard it how well it works or squeezes, they actually tend to have a normal pumping fraction or ejection fraction. But the problem for women is often the relaxation of the heart muscles. So again, if we're not looking for it, it may not get detected. So a whole long list of extra conditions that are more common in women and not always recognized. The risk factors for developing heart disease and stroke are pretty similar at men and women. So the classic ones are high blood pressure, diabetes, both type 1 and type 2, smoking, high cholesterol, and having a family history or genetics. And we know that this is the backbone of heart disease, or what leads to hardening of the arteries. However, we know that these risk factors are different in women. And so women with high blood pressure later in life actually have more high blood pressure than men. And the Canadian Hypertension Canada looked at treatment in women over the last few years. And over the last 10 years, the treatment for high blood pressure in women has gone down. So we're not treating women's high blood pressure to the same level that we should be for to prevent a heart attack. Similarly, we know that diabetes in women with is also less treated as well. So as a community, we need to start saying, hey, we want better treatments for our high blood pressure and diabetes for both men and women. We also know that there's some other modifiable risk factors. So physical inactivity is a high risk factor. And again, that's where the recommendation of 150 minutes a week of physical activity. And so that's low to moderate, well, generally moderate physical activity, about 30 minutes 5 times a week, or about 22 minutes a day if you'd rather do it daily. But we know that that's enough to prevent heart disease. Diet, so avoiding high salt and also having more fruits and vegetables is protective. And then maintaining a healthy weight, so preventing obesity or keeping their body mass index in the normal range and in the non-obese range. So obese being a body mass index greater than 30, we know is unhealthy and relates to heart disease over time. Stress is something though that I do want to mention, and I'll come back to it again at the end of the presentation, because of COVID, stress levels have completely changed in Canada and globally. But we know that stress is certainly more common in females, and there's a lot of additional stress factors for women. And we often talk about reducing stress levels, but that's kind of one of those things that's easier said than done. And when we talk about stress management, about, how do you cope with the stress, exercise, meditation, wellness, yoga. One of the things that I've learned from women with lived experience that I work with nationally is that it's not just managing the stress that you have, it's avoiding it. How can we reduce the burden of stress in general? And so strategies around stress reduction are probably going to be more effective than just how do you cope with the stress once it's started. So what's important though is to understand is that at least 90% of people in Canada have one of these risk factors, and they're the same risk factors that lead to heart disease, stroke, and dementia, and that preventing through lifestyle can actually dramatically reduce these risks long term, and that it's never too late to start either. In terms of when you go to your family physician, some of you may notice that they do a calculator while you're there. And oftentimes we love these risk calculators as internal medicine specialists to try to predict how high is someone's risk of having a heart attack or a stroke in the next 10 years, because that actually dictates, how intense do I need to lower their blood pressure, or how intense do I need to lower their cholesterol? But what we know is that these risk prediction models were typically done in men. And so they often underestimate a woman's risk of cardiovascular disease. A woman doesn't get as many points as a man. And so we're now realizing that a lot of these risk predictors need to be changed. Canadian researchers at McGill have developed a Canadian version called the Canadian Life Expectancy module, but I don't know if it's being commonly used in primary care. But this is where the family doctors and cardiologists and internists have a limitation, that the tools that we're given are not as accurate in women. And so that's certainly a research gap there and something we need to be aware of. I want to move on a little bit to testing, because testing, comes up that as a challenge in women. The typical treadmill stress test we know is less accurate in women. And often then, because of that, that leads to extra tests that women need to go through. Part of the reason why it's less accurate is how they were developed and the normal ranges were established, but also with the breast tissue and where the electrodes go for different imaging, it's very difficult to image. So again, we need to get better tests for women as well. But we also know that women with abnormal testing don't go on to complete the full testing. They're not referred for angiograms. And so we're working on strategies to reduce that or improve that. So how do we prevent heart disease and stroke? And a really good resource is Heart and Stroke Canada. And they have excellent websites with healthy meal planning, for example. I took a screenshot of that. There's lots of information for recipes, heart healthy. They also have good information about exercise. Stress management section is excellent. But yeah, these healthy tips, again, about physical activity, a heart healthy diet, low salt diet, and maintaining a normal weight. I know sometimes it's things that we all know, but we all have room for improvements, myself included. And these resources can be very helpful, again, towards just simple, small changes we can make on a day-to-day basis that have long-term benefits there too. And you can see up here on the Heart and Stroke website, they actually have a special dedicated section for women too, if you do want to look at that. So preventable. But what about when someone gets heart disease and standard treatment? So we know everybody loves to talk about statins or the cholesterol pills, and now the ACE inhibitors and ARBs are hot pressed because of COVID, et cetera. But we know that there's a whole cluster of standard therapies after someone's had a heart attack. So a beta blocker to slow down the heart rate, a statin to lower the cholesterol and help with the blood vessel wall, ACE inhibitors as well from a blood pressure and remodeling perspective, and aspirin. But if you look here in Canada, so this is coming out of Alberta here, that this side of the line here, this 1.0 line, says favors men, meaning more men were on treatment than women. You can see here that women were not treated as aggressively with the same standard evidence-based therapies that we know works. We don't know why that is. If they're just not prescribed at the time of discharge from hospital because it's thought that, oh, maybe they aren't, maybe a bit more frail and can't withstand a lower blood pressure. But we know women can tolerate a lower blood pressure. We don't know then it's that women don't have the opportunity to go fill their prescriptions at the pharmacy if they don't have transportation or financial resources to pay for prescriptions. So we don't know why women aren't on the same medications, but this is a question you can ask your doctor. Am I on all the right medications? Is there anything that I'm missing here? And we can take ownership of our own health to make sure that we're on all the right medications there. Because not just in Alberta do we see this trend, but we see it across Canada and internationally that women aren't prescribed the same medications. But what's really interesting is this whole concept of with different diseases that women had, do they actually need different treatments? And Here in Calgary, Dr. Ed O'Brien in his lab is looking at the cholesterol side of that equation. Do women need different cholesterol treatments? Do they metabolize it the same way? Again, with research being focused on men, maybe this is why women have different biology. We have different sex hormones. Estrogen levels change the cholesterol levels. It's really complicated or multifactorial. So how can we separate that out? So through his animal models, he's looking at different cholesterol pathways and whatnot. Our group also found that when we looked at the blood pressure studies, that over 90% of the studies do not actually look at the differences between men and women. So again, how can we tailor treatments to both men and women if we're not looking at that question? So as a scientific community, we need to do better. And we also know that from a prevention perspective, that aspirin doesn't work as well at preventing the first heart attack in women. It prevents the second heart attack well, or what we call secondary prevention, but it doesn't work well for primary prevention in women. So that's been taken off the list of preventative treatments. So again, it's important for us to look at these questions. Now, what about a course of over a woman's life course, all the way from being a teenager, a young adult, pregnancy, and postmenopause? And I put this slide together showing how different conditions affect a woman over her lifespan, and I'm going to get into some of these, that actually raise her risk of heart disease. And maybe we can prevent this in subsequent generations. So if I talk about fertility, we know that polycystic ovarian syndrome, and some women in this audience may have had this as a teenager growing up, irregular periods, and their ovaries when on ultrasound have lots of cysts. But we know over time that that group of women actually has a higher risk of developing cardiovascular disease because they tend to get over excess weight, diabetes, and fatty liver as well. So they're more prone to cardiovascular disease. Similarly with endometriosis, that's when the endometrial lining inside the uterus grows outside of the uterus. For reasons we don't really understand, this is also associated with high cholesterol and premature hardening of the arteries too. We also know that women who had troubles with fertility, so maybe they needed fertility treatments or had early failure of their, early ovarian insufficiency, or their ovaries, they went through premature menopause, that those women as well have an increased risk of cardiovascular disease. We know that they get higher cholesterol, diabetes down the road, and are prone to having heart attacks in the future too. So we've got these groups of young women that maybe we can do something about it in the future. Similarly, pregnancy, there's been multiple articles in the lay public and in our scientific literature saying, wow, pregnancy identifies women at risk. Let's use this as an opportunity to intervene. But I think what's more powerful in this is the lay messaging. So some of you may have seen this article in Chatelaine that came out about 3 years ago, actually really describing this link between these pregnancy cardiac complications and future health. But this data goes back about 10 years, and you can see from the bottom of this article, 15 years now. This came out in 2005, and we're still catching up. And what this Ontario study showed is that if you followed women with different types of pregnancy, high blood pressure conditions, that they started having heart attacks early, and that their first average age of their first heart attack, stroke, or mini stroke was at 38 years old. And our system down here, this was in 2005, has done very little to try to catch up to this knowledge. And this is what the research that my team drives forward, because we know that these women had a doubling of heart attack, stroke, etc. But the key here, it was premature in their 30s and 40s. And so when we summarize this, we know that women who've had high blood pressure or preeclampsia, it often was called toxemia, high blood pressure and swelling. And years ago, women were just told, many of you in this audience may have had it, oh, don't worry, it just goes away after you deliver your baby, you're fine. It might come back in the next pregnancy, but until then, you're fine. And I think we didn't know very much back then, but now we know that these women are on the track to developing high blood pressure, heart disease, stroke, arrhythmias, that's that fluttering of the heart failure, 4 times likely to get heart failure, and premature death due to cardiovascular causes, and everything from head to toe, seizures, dementia, high cholesterol. So again, we're ignoring this window of opportunity to intervene early, and this is what our work focuses on. Preterm birth, you may have seen a lot in the literature coming out showing that women who've had preterm birth below 37 weeks, or specifically below 32 weeks, have a doubling of the risk of premature heart diseases. And that was whether they had a reason for the preterm birth or if it just happened spontaneous. And when we think about why that might be, preterm birth is often more common in women with more complex social situations or different races and ethnicity. And so maybe there's like other components outside of just the biology of the blood vessels that's impacting health too. So I summarize all the pregnancy risk factors, and you can see there's a huge long list and it's growing. But the key is these abnormal events in pregnancy put a woman on a pathway, and we have this opportunity to intervene in your children and grandchildren and whatnot. What about menopause? So this is a question we often get, that we know before menopause, women tend to have a slightly lower risk of heart disease and stroke and high blood pressure. And then after menopause, the um, um, after menopause, this rate increases, and that women often surpass men in terms of the incidence or amount of heart attacks and heart disease out there. And a question is, there's slides from my colleague, Dr. Sophia Ahmed, a kidney specialist who researches this area. And this area is really difficult to follow. I think in the lay paper, we get articles, oh, hormone replacement therapy is good. Oh, now it's not good. What do we do? And that messaging is really complex. And this often requires a long conversation with your doctor about what's right for you, because it depends a little bit on time, how old you are, your age, because if you're after the age of natural menopause, then oral hormonal therapies may increase your risk of heart disease. But if it's a different type, if you're less than 52 because your ovaries have been removed for some reason, then in that case, it is beneficial and protective. It also depends on the type of estrogen and the hormone that you're getting. If it's topical for, vaginal symptoms or dryness, that doesn't seem to increase the risk. So really complex for the whole, for a short talk. But again, this needs to be individualized in a thorough discussion with your primary care provider about postmenopausal therapy. So we've talked a lot about biology. What is the biology of that may explain some of the increased heart disease risks in women? But one thing that's important to talk about is the social context, or what's often labeled as gender. And this is sometimes where people in the audience get a little uncomfortable. Oh, well, we're all the same. But we know that there's a little bit of difference. And I'll just point out a few. That there's this concept that women are juggling very many roles as caregiver, parenting, caring for their elderly parents, managing relationships, the household, and whatnot. And we know from that women often put their health needs below the health needs of their families. And so this is sort of what we call a gender behavior, and that we need to actually change our therapies to allow women to put themselves first, to take that time for exercise or to go to their appointments. And Dr. Karen Humphreys from BC says it really elegantly, if we don't take off these gender blinders, women are going to keep dying. We're not doing the right treatments. And this is what we found in our clinic, is that women don't come back after the babies. We lose 50% to follow-up because they just are too busy at that stage in their life. So how can we do better to address that? But we know it's important to study these social roles, because what Dr. Colleen Norris from Edmonton found is that we all have a combination of what's considered to be a standard male versus a typical female trait, and that proportion of those traits actually does impact your outcome after a heart attack. And again, is that because women then are maybe not taking their medications or have the opportunity to fill their prescriptions? We don't know, but this area is growing. But the messaging here is that we need to encourage women to put their health needs on par with others. And COVID has really accentuated that. I think, when we talk about the COVID crisis, there's so many issues that have come up at a societal level, a health level, et cetera. But what we're really seeing is different outcomes with females, that women now really need to advocate for their own health, much more stress in women, et cetera. And so this, this reminder from the American Heart Association, or CardioSmart, is that even though there's restrictions and no one wants to go to the hospital, but what we really want to do is make sure that you take those symptoms seriously and still call 911. If you're having the chest pressure, tightness, shortness of breath, nausea, don't put it off. We don't want you to delay visits to the emergency department. We still want you to go. It is the COVID precautions at the emergency department are really well done. And we know from Alberta data that people are waiting too long to go now because of this fear. And we want you to put that fear aside and just go to get assessed to see if your heart is okay. So if I summarize, there's a lot of conditions that both males and females had relating to high blood pressure, diabetes, obesity, and stress that can all be managed through lifestyle. So, lifestyle plus drugs when needed, but physical activity of 150 minutes per week, healthy nutrition strategies as well. But when we talk about females, we need to start thinking about other reasons. So the pregnancy complications, how their biology is different, and they may metabolize drugs differently. So at the end of this talk, I hope that we've educated a little bit about heart disease, and that encourages women to bring up the conversation with their primary care team, reinforce that lifestyle does prevent about 80% of heart disease and actually controls it. So even for people who've had a heart attack, all these healthy lifestyle tips do actually help with controlling the disease long term. So I really like this concept here, and it comes up in a lot of advertising for heart. Know your numbers. What are your numbers? And asking your doctor, like American Diabetes Association, American Heart Association, they always say, know your numbers, know your score. Like, what is your risk score? If you know what your risk is, you're more likely to actually pay more attention to it, get your blood pressure down, get your cholesterol down and everything. So really, one message here for everyone is really that conversation with your team about, where are your numbers? Are they in the safe range, or are they in the green range and whatnot? So I hope that was somewhat informative for the audience today. And now I'm happy to take any questions. And I see quite a few here, so I can see them actually. So so the first question from Suzanne is, how do ACE inhibitors and ARB drugs work? So that's a really good question, Suzanne. And I think that there's been a lot of data out there with COVID and looking at some of the information. So ACE inhibitors and angiotensin receptor blockers act, at the kidney level in this complex blood pressure pathway to lower blood pressure. And they do have impacts on the heart as well, remodeling of heart vessels too. So again, overall, the messaging, if this question comes from the COVID literature, is stay on those blood pressure pills, don't stop them. We want people to stay on those medications. Another question I see here is from Susan, a cardiologist I've been referred to does a yearly checkup, echo and treadmill and blood tests. What else should be considered? That's a great question. And we need to do that it's hard to give a general answer to that because it really is an individualized question based upon your risk factors. Do you have a family history? Have you already had heart disease? Do you have high blood pressure and diabetes? And also, what is your age? Because we know that with higher age comes higher blood pressure and diabetes. So generally on an annual basis, if someone hasn't had heart disease, it's often screening for cholesterol, diabetes, or pre-diabetes screen, and that's often it. The added stress test and echo is variable in someone without heart disease. If someone does have heart disease, though, then the echo and the treadmill may help inform the progression of underlying heart disease. So that's often more commonly where it's used, is in people who've had heart disease. Another question here. Yeah, and so I think the question sort of relates to echo of leaky valve, and it's probably that that leaky valve is being followed every year. We do know that once cardiologists have found a leaky valve or a tight valve, often the follow-up is with an echo. That's the ultrasound of the heart to get a better picture of the heart. And the frequency, like how often that needs to be, can be every year or it can be every few years. It just depends on how tight it is or how loose and how fast it's changing. So a lot of features will go into how your care team is planning to follow up those conditions. Oh, so this is a great question. The next question, oopsie, I already, is, does the intensity of exercise matter, or is it more the consistency of any exercise? So that's a great question. And again, it's hard to pay attention in the, it's hard to keep track of in the press, because every few months, there's another study that comes out and says, oh, now you only need to do high intensity exercise for 7 minutes at a time, or no, you still need to do 150 minutes a week. So to answer that question, we do know that it's the length of time and the intensity that matters. But when we talk, so we know from our very big studies in the US and overseas in Europe, these prevention studies, they generally split patients into getting 150 minutes of activity a week, and those groups actually did better. So that's where 150 minutes comes from, the duration, and the intensity is generally called moderate to vigorous physical activity. So that means something different to everybody, because it depends on what activity you like and how fast it gets your heart beating, and if you're in shape or if you're not in shape. Because starting out, no one's in shape when they start out. So to answer that question, it's anything that really gets your heart beating so that you're a bit breathless, that you can still talk but that you're a bit breathless. So again, that intensity, if you're out for a walk and it's easy and you're talking to your partner and having a nice conversation, speed it up. Like that, you can speed up a little bit. But again, it's what are you going to do? So as much as I can tell you, yeah, go get a gym membership and go and ride the bike and do some weights, if you're not going to go, well, especially during COVID, sorry, I shouldn't say that during COVID, but if you're not going to do it and you don't like it. So my question to my patients is, what do you like? And some of them say, oh, I really like to dance. And so we talk about how can you get a dance video? Other people say, well, I don't really like going outside. Well, how can we bring the bike inside? So, again, how do we problem solve for these long Calgary winters? It's at the end of the day, the more you move, the better, and the less you sit, the better. So what we do for some of our patients is, instead of sitting to watch a television show, could you stand? Could you do some little leg movements while you're sitting there? And again, it's really depends on your mobility and what you're able to physically to do. So great question there for that. Okay. We're getting more questions. I got to speed up my questions. Sorry about that. Okay, so this is a great question from Maureen. Does having rheumatoid arthritis increase your risk of heart disease? And so this is a really new area of research, and it's showing that all these families of arthritis diseases, so rheumatoid arthritis, lupus, that have inflammation where your body, gets attacked by inflammation of the joints or organs, that inflammation actually can accelerate heart disease. So a lot we're learning there. We don't have specific information yet, other than just controlling the underlying rheumatoid arthritis or lupus, et cetera, tends to do better. We also know that some of those rheumatologic diseases can specifically affect the heart directly. So the lining of the heart, the pericardium, like the sac around the heart, and the heart muscle. So the keys really to anyone with an underlying rheumatologic disease is if you have cardiac symptoms, don't ignore them. Don't think they're going away. Get them investigated. Get them investigated. So a question relating to aspirin and allergies. So ASA, if you're allergic to aspirin, yeah, so this is a complicated question. If you're allergic to aspirin, then you can't take it if you're, depending on the severity of your allergy. And it'd be important to clarify that with your care team, what type of allergy. We know that preventing heart attacks in the first place for females, aspirin isn't effective. And so it's just for that, after you've had a heart attack, a stroke, you need an aspirin type product, but there are other ones, there are other options if aspirin is not on that treatment list. Oh yeah, okay, so a good question. As a gynecologist, should I be more concerned about the perimenopausal or the menopausal patient with an apparently low risk profile otherwise? Yeah, I think we're evolving our research in that area. Again, so there's a couple concepts there is we do want, when we talk about this apparent risk of like they look low risk, they might have a normal body mass index. We don't know until we check the blood work though. So definitely those women, if they're perimenopausal, should be having, a cholesterol screen if it hasn't been done, and a pre-diabetes or diabetes screen. And then that can certainly help identify. I think both are high risk groups, and the earlier we identify someone at risk, the earlier we can intervene. So I would say both of them. The menopausal woman will have a higher statistical risk of heart disease, but that perimenopausal has longer time. And if we intervene earlier, that's the group that I would focus on. Okay, yeah, so there's always a lot of questions about statins. And so a couple of questions about statins. So statins are the cholesterol lowering pill. And so there's a couple questions here. Are there other options? And can they cause or contribute to diabetes? And so probably statins get a bad name in the press. No one likes a statin. I find there's such resistance to prescribing a statin. There's so much resistance from people to take a statin because they hear from their friends that they had muscle aches from it, or in the news there was a reaction. Statins are excellent drugs. Like they actually really lower the cholesterol well. If people are not tolerant to statins, there are other options out there. So there's a whole new group of statins coming out that, or sorry, not statins, but cholesterol pills that can be taken less frequently, like on a monthly basis. Some are these PCSK9 inhibitors. They're just not covered by all drug plans. And again, it sort of depends on your risk profile there. So good question, Isha, about AMH. I think you're the gynecologist here. Yeah, low AMH and cardiovascular risk. So that's coming out in, like, that's a new association. So AMH is that female hormone, and men have it too, that it's a low association. It's sort of in that 1 to 1.5 times increased risk of cardiovascular disease. And there's some groups here in Calgary working on those fertility hormones and cardiovascular risk. The fertility data is very conflicting though. And when we look at it at a population level, so I think that looking at it at a biological level with AMH is going to help sort that out a bit more. Okay, I love this question. I have Turner syndrome. So for people who don't know what Turner syndrome is, you may know people with Turner syndrome and just didn't know they had it. It's a chromosomal abnormality. So within each of the cell, we're supposed to have, 46 chromosomes, and females biologically have an XX, or men tend to have an XY. And so Turner syndrome, they have one X chromosome. And this brings up a huge area of research that's just not known. And I think that in the last 5 years, the government of Canada and Heart and Stroke have really said, we need to study this biology better. So as much as I talked about, we don't know a lot about between males versus females from a biological perspective, we know even less about people's future heart risk if they have different chromosomal structure and different chromosomal profiles. So I think that that's coming. I think that definitely you do need to have some conversations about your, your actual hormones, depending on your age and whether you need hormonal support from a protection perspective. But again, really, that's a great question to motivate researchers to actually look at that. So I see a whole bunch more questions here. Colleen, am I okay just to keep going? There's a few minutes left.
We have flexibility here, and I think that it's important to get to those answers for these people.
Great. Okay. So on to the next one here. Yeah, so this next one is from Sheila about an arrhythmia and now entering menopause and the heart rate variability. And, it can go really fast, it can go really slow. So your question has, some specifics for you, but for general points, a couple of things here, so those feelings of palpitations, they need to be investigated. So if you've already been investigated, excellent, but we like to investigate those palpitations because we want to make sure that they're not a dangerous heart rhythm. We all have skip beats from time to time, but the key here in this comment is near blackouts when I stand up. That can be related to blood pressure and blood pooling, but blacking out is a warning sign that we need to investigate that. So I would certainly encourage people who are having those blackouts or near blackouts. Those are symptoms we do take very seriously as healthcare providers, and would ensure that investigations are done. So great question. Yeah. So I'm just gonna see if there's okay, so I'm just trying to see if any are grouped together. Diet, yeah, there's a lot of questions out there about diet. This one here is about high protein, low carb, and heart attack. I think we don't probably know enough about all the specific diets, and some of the diet studies aren't studied in a really strong, rigorous way. We do know great information about diet can be found on Heart and Stroke's website. And they talk about a lot of different diets. And also the Canadian Cardiovascular Society has a lot about diet, because we do know that some of the proteins are really helpful. Some of the studies have looked at like high protein coming from nuts and different food sources. So it really depends on where the food sources are and how they're balanced. And often that's actually worth an actual dietitian consult, beyond just a website. Is having a dietitian consult can be really important for identifying hidden fats, hidden saturated fats that you may not be aware of, because sometimes it's hard to read the labels. So yeah, as a general question, we don't know specifically about high protein, low carb, because what it really depends on is what's the fat intake there and the cholesterol intake, and how is it changing your specifics. But what I will say about diet in general is generally diets, if they help you to lose weight, they can tend to be beneficial. But yeah, we're getting a lot of questions now about like the keto diet and all these different things. And I think that they're a bit difficult to answer in a lecture, but that's where an individualized dietitian consult, if it's available through your family health team, is a really great starting point. Okay, so aspirin. This one I'm not totally sure. So aspirin, I was told that aspirin should not be taken with blood pressure medications, just Tylenol. So Tylenol and aspirin are two different kind of families of drugs, and so they work in different ways. And aspirin with blood pressure meds, it can be taken at the same time. It doesn't have any interactions. And in fact, we do know from some studies coming out of McMaster University and internationally that if we combine drugs into one pill called a poly pill, so if we combine like different drugs into a pill, you actually get better effect. Not just because you're taking it more regularly, but you actually get better effect. So yeah, you can take aspirin with blood pressure medications, but you may just want to check in with your healthcare provider in case there's a specific reason that was told to you. Again, aspirin works differently than Tylenol. Okay, so okay, so the next one here is, Suzanne's asking a really good question. How are SCAD, microvascular, Minoca, and vasospasm diagnosed? And that's the diagnostic dilemma. That they're so oftentimes it depends on what city that you live in. And so in larger cities, there often is one expert, or maybe a team of experts in that city that actually deal with the diagnostic tests for these conditions. I think in 5-10 years there'll be more people that do it, but the tests are a little bit different. And so it often starts with having the regular exercise stress test and echo, and if those are normal and a woman's still having symptoms, it may proceed them to have further investigations. It's often they need to have an infusion. You have to has it done in a lab setting where there's an infusion of a medication to see if it can cause the vessels to spasm. Not every city has that. So oftentimes for women, if they're suspecting microvascular disease, they'll, or the vasospasm, they can give them a spray of nitroglycerin that goes under the tongue. So some of my patients, I say, I can't really diagnose this, but let's do this kind of as a test. And I give them a prescription for the nitro spray. If they find that it improves their symptoms, then we might be on the right track with that. Again, the key for those is ruling out like big blockages. SCAD and Minoca are typically diagnosed with an angiogram, and SCAD presents a lot like a heart attack and whatnot. Okay, so hypothyroidism. So thyroid medication can be taken with high blood pressure and high cholesterol medications. There's generally no interactions with that. And we find that once you treat hypothyroidism, blood pressure might come down a bit and cholesterol might come down a bit. Someone's asked me a really hard question about potassium and heart health. We know a little bit less about potassium, and in heart health, we know about it more in relationship to blood pressure. And I probably won't get into that too much because it's pretty. Hypertension Canada does have a recommendation for potassium in the diet, but again, that is a pretty specific nutrient that if you go too high or too low, it can have very adverse health impacts from a muscle, kidney perspective, etc. So I'd certainly suggest specific data from a dietitian about that. So,
Dr. Nerenberg, we seem to have some questions in our chat box. Are you able to access those?
Yeah, just give me a second. What did I do? Chat box here. Okay, here's the chat box.
Down on your menu bar there.
Oh, wow. Okay, there's a lot here. Okay, sorry guys. Okay, so we have that one, that one. Yeah, so okay, so some of them are kind of been answered. The shortness of breath symptoms for a female is an important symptom to investigate because a comment that came in Sandra's comment here is, is it related to anxiety? And anxiety for me is always the last choice. I think for some doctors, they think, oh, it's just anxiety and whatnot. I always leave that at the very, very, very end, and specifically try to get people tested for that with a psychiatrist. We work closely with some psychiatrists in that regard too. Shortness of breath, though, does require investigations, and I always start off by telling my patients that this is going to take us a little time to get to the bottom of, because we may have to start with cardiac tests first and then go with lung tests and then go with others. So it definitely does need to be investigated. And certainly for Sandra, having had your pregnancy history of that, you do have a higher risk of developing cardiac conditions. So those should be on the list of tests there as well. Aspirin is safe for stroke prevention. Again, it's more being used now to prevent the second stroke than the first stroke. And the Heart and Stroke came out with a guideline for that for your doctors. And yes, it is safe to exercise with AFib unless your doctor has specifically told you not to. But in general, for most patients with AFib, we do recommend ongoing exercise. Family history question is a really good question, and sometimes we don't talk about this in our family, like who had heart disease, who had a stroke, what did grandma die of, what did grandpa die of. And so the more information you have about your extended family members, the more helpful that is. And so we often talk about first degree relatives, so your mother and father and your children, and then we talk about second degree where we branch out. But really painting a picture of that, and a woman who just presented at our conference said she was only ever asked about her parents, and then when she started saying, well, my grandma and my aunt and my uncle, it led them down a track of investigating for a genetic cause, actually. So the more information you can bring to your healthcare provider about your whole family, so aunts, uncles, grandparents, parents, and your own children, if you have any, that helps us try to sort out what condition and maybe if there's a genetic relationship there. So yeah, so the blackouts and the palpitations can be hard to pick up. As we all know, they come and go. And so if you just have a one-time ECG, that's going to look for something really big and scary that's happening right now. But again, because these things come and go, that's often where we put people on longer tests. So a Holter monitor for maybe a day or for 2 or 3 days to try to pick things up. And there's some really neat technologies now that I don't know, but using your iPhone for these types of things. So yeah, so hopefully we'll get more information there as well. But yeah, so I think that from what I'm seeing here, I got all those questions in the box there too.
I think you've tackled most of them here. Quick question I have for you is the relationship between heartburn, GERD, and heart attack. Is there any correlation there at all that sometimes you think you're having a heart attack because you have heartburn?
Yeah, and when I always get my patients to say, what do you mean by heartburn? Tell me what that feels like, because we label a lot of things of heartburn or indigestion that actually are angina, that are actually true true heart symptoms. And so I think that's again where really being clear with your care team about what it feels like. Is it worse with food? Is it better with food? Is it only brought on by a heavy fatty meal? Those things make it look more like GERD or heartburn or reflux. And then also that it gets better with taking the right treatment. So it gets better with taking antacids over the counter, or it gets better with taking prescription medication. And the keys are, like, if it's exertional, if it's happening when you're exercising, that's usually not heartburn, that's usually your heart. So if your heart has to work harder and you're getting symptoms, it probably is pointing towards your heart. Yeah.
Good to know. Something you need to pay attention to. And I think that the correlation between the reproductive issues that you referred to and the instances of heart attack were absolutely mind-boggling. I had no idea. So fascinating information. Thank you very much. It was I think you gave us a lot to think about, a lot of great information here. And I do have to commend you for the work that you're doing, not only in the research, but in the advocacy to build the awareness for the need to address this issue that seems to be lacking. We chatted just briefly before we opened about the presentations that you did on the weekend as part of the Her Heart Matters and Wear Red Canada campaign. And it sounds like you caught the ear of some very important people. Would you like to chat about that presentation a little bit? And is that available on video for our viewers to maybe take a look at?
It is, yeah. I'll get you that link, Colleen. I think they said another week or so. So on the weekend for Wear Red Canada Day, and again, it was a trying to be an awareness campaign that women's heart disease is different, and that women need to be aware of different symptoms and make sure we advocate but also it's a real push to clinicians and researchers to say, wow, I need to manage her differently. I need to take this seriously. And also, wow, we need to research better treatments. And so our advocacy campaigns on the weekend targeted women, and it was done through Heart and Stroke, and the presentation will be there, and it was about women's risk across her lifespan from, before pregnancy, during, and after, and then the impacts of COVID. And it was a pretty good talk. But what was really important was that we actually had some politicians involved. So Mayor Nenshi, Mayor Iverson from Edmonton, and Tyler Shandro, again, they were all involved with messaging to say that, today is Rare Red Day for women's heart health, because if we can actually involve the politicians, we can actually start changing health policy to get resources for women's heart health. And so the federal government, I have a meeting with them in a few weeks. Hopefully that goes well. But what they have committed, they committed $5 million. So my research is funded because of this, to close these sex and gender gaps. And we're advocating for them to renew that funding for 5 more years, not just for me, but for all of women's heart health. Because again, some on Twitter, Justin Trudeau announced heart health, but what for women, and the comments, well, men have heart problems too, and they do. And this is exactly the point, is that if we better understand the biological differences and actually start to study women, we can actually improve treatments for both males and females. So yeah, so it was an exciting presentation we did to have the politicians in there, and really talking about what this is like on a day-to-day basis for their family members too. So we're hoping that this way we can get more funding for programs and for prevention programs, and for some of the testing that was in the side there, like we don't have the resources in small communities, and we need to start directing there too. So
well, congratulations. We wish you well with that, and I'll look for that link that we can share. We were also provided with a video from Heart and Stroke, the Calgary office. Unfortunately, we didn't have opportunity today to be able to have the time to show that as well. So when I share the link with all of you to be able to access the recording of today's presentation, I'll provide you with the links for Dr. Nerenberg's presentation last weekend and the video link, so that you can view that at your own leisure as well. And I think with that, lots of great accolades here for you, Dr. Nerenberg, and thanks from our viewers. And I'm just going to take a minute here and just do a quick screen share as well. And again, thank you very much for what you're doing and the information you've shared with us today.
Well, thanks for the opportunity today.
And again, there we go. And again, thank you all for joining us today, and particularly to Dr. Nerenberg for such great information. I know that I learned a lot. I feel that the need to go and make sure that I find out what my numbers are. And for those of you that looking for other services, Kerby Center is still essentially closed to the public, but we are open and available to offer all of our programs and services. So please feel free to call our main line at Kerby Center, and or visit our website, www.kerbycenter.com, to find out how that you can access those presentations. And of course, always, if you're in distress, as Dr. Nerenberg referred to, these are times that are very stressful for everyone. If you need support, please reach out to the Distress Center line there. Also, our 2021 memberships are available for renewal currently. And it is income tax time. So if you need some support with getting your taxes done, Kerby Center is offering a free tax clinic for you. So you can contact them at the 403-705-3246 and make arrangements for an appointment. And hopefully you'll all join us for some fun next week. We're in the midst of Chinese New Year celebrations, And on February 23rd, we're working with the Calgary Chinese Elderly Citizens Association to present a virtual Chinese New Year. Many of you know that we usually do a celebration in our auditorium. This year we'll be doing it virtually with lots of video performances and a little bit of fun learning calligraphy and the art of paper cutting. So please register for that, and we'll get that information to you ASAP. And we're already into planning for March, so that information will be coming out to you as well. We'll submit that, we'll provide that with the links that we referred to earlier. And again, thank you all for joining us today. And we look forward to having you join us again next time. Dr. Nerenberg, thank you so much, and we'll be happy to watch your progress on your success here. Thank you all very much for joining us.
Thank you. Bye.